Kia ora. This is just going to be a whirlwind tour through what is known as a hemiblock or a fascicular block that might show up on an ECG. The fascicles are divisions of the bundle branch. So in a nutshell, the left bundle branch is going to divide into two major fascicles. And it's these that are going to continue the depolarization sequence from the bundle branches out to the Purkinje system. The largest of these fascicles is the left anterior fascicle. So it's a continuation of the superconduction highway to the lateral and the anterior portions of the left ventricle. The other principal division is the left posterior fascicle. So it divides from the superior portion of the left bundle branch and it heads more rearwards around the posterior, and it conducts the depolarization sequence to the posterior wall of the left ventricle. So a fascicular block occurs when one or more of these fascicles is blocked. And unlike a bundle branch block, a block in a fascicle has a relatively minimal effect on the speed at which the depolarization wave is going to spread through the ventricle. This is because a block in one fascicle will not disable the others, and so a portion of the depolarization sequence is going to be conducted via this faster system. The general rule of thumb is that fascicular blocks will have a marginally widened QRS, but they're unlikely to exceed the threshold of 0.12 of a second. Now, the blocks are sometimes called a hemiblock, and they should never be confused with the powerhouse of the iconic 1970s Valiant Charger. The most common of the fascicular blocks is that affects the left anterior fascicle. Now, if this is the case, the initial part of the QRS is dominated by the signal continuing into the left posterior fascicle and initiating a depolarization sequence in the septal region of the left ventricle. The dominance of the septal depolarization means that the right-sided and inferior leads are going to see a small R wave at the start of the QRS complex. Conversely, left-facing and lateral leads, such as 1 and AVL, is going to see this as a small non-pathological Q wave. The slight delay caused by the fascicular block in the anterior fascicle will delay the depolarization of the lateral and anterior wall. This is going to have the following results. Firstly, the initial predominance of the signal carrying down the right bundle branch causes a small positive deflection in the inferior leads. The reciprocal changes are seen as non-pathological Q waves in the left-sided leads, such as 1 and AVL. Secondly, the fascicular block results in a small delay before the depolarization sweeps across the anterior and lateral walls. Once it's initiated, it causes large R waves in the left and lateral leads, while the anterior leads will see the opposite and show deep S waves. So, one of the distinguishing characteristics is RS complexes in the inferior leads, while the left lateral leads are going to show those non-pathological Q waves. The delayed activation of the left ventricle swings the RS vector to the left, and so another significant finding in these left anterior fascicular blocks is going to be left axis deviation. The delay in initiating the lateral and the anterior wall shows us a slight lengthening in the initial phase of the QRS. This phase is known as the ventricular activation time, or VAT, and is measured from the initial deflection of the QRS complex to the peak of the R wave. Typically, this is less than 0.04 of a second, but will be lengthened in the fascicular block. While the QRS might remain less than 0.12 seconds, the VAT will be prolonged and it may exceed 0.04 of a second. So let's review what we've covered so far. A block in the left anterior fascicle produces a left axial deviation accompanied by non-pathological Q waves and dominant R waves in the left and lateral facing leads, and confirmation is achieved by finding small R waves but deep S waves in the right-sided inferior leads, such as 2, 3 and AVF. Final confirmation can be found by looking at the ventricular activation time, so the early phase of the QRS is quite likely to exceed 0.04 of a second. This brings us to the less likely of the two types of fascicular blocks. The posterior fascicle has more protective mechanisms against injury, so it's got a slightly wider distribution and a more diverse blood supply to protect it from ischemia and injury. So the incidence of blockage to this fascicle is very low. The depolarized sequence associated with a posterior fascicular block is going to initiate the polarization of the anterior and lateral walls unopposed. And it's going to result in a small and an early negative wave for the inferior leads. In other words, you're going to see a non-pathological Q wave in leads such as 2, 3, and AVF. As the delayed depolarization sweeps via the Purkinje system from the lateral to the inferior walls, and more rightward aspects are missed by the. If we were to stick with the pale mnemonic, these changes are going to be reciprocated in the lateral leads. So in this case, leads 1 and AVL are going to have small R waves followed by deep S waves. Another confirming factor for a posterior fascicular block is going to be a rightward axis deviation. Left posterior fascicular blocks are rare, and the diagnosis is one of exclusion. That is to say that other causes of right axial deviation, such as right ventricular hypertrophy, or a right bundle branch block, or right ventricular overload, such as may occur with a pulmonary embolus, or limb lead reversal, needs to be discounted before settling on a left posterior fascicular block as the final determination. One more point to make. People will talk about bifasicular blocks, and generally speaking, what we're talking about is a right bundle branch block that coincides with either a left anterior fascicular block or a left posterior fascicular block. The ECG characteristics of a right bundle branch block remain unaffected, so you're still going to see a wide QRS with an RSR pattern in the septal leads and slurred S waves in V1 and V6. The distinguishing features that indicate a contemporaneous or a concurrent left anterior fascicular block are going to be left axial deviation and an RS pattern in the inferior leads. Remembering that left posterior fascicular blocks are very rare, but should they occur in the presence of a right bundle branch block, you're going to have extreme rightward deviation. The clinical significance, well, in the presence of an acute myocardial infarction, the clinical significance is that the block is more likely to progress to complete heart block. And this is an indicator of increased likelihood of severe or deadly consequences. That brings us to the end of the session. If you've got any questions, feel free to get hold of one of us. In the meantime, ka kite.